from anterior to posterior throughout, then you can use three needles. So if it is only along the posterior part, you can use one needle. So it basically comes with experience. So even without a transrectal ultrasound, if you have done actually the planning of patients consecutively, even clinical examination, you get some idea that how many needles you need based on how thick the parameter disease is. And we can also look at the disease extent at the time of diagnosis. So if you have a diagnostic MRI at the time of pre-EBRT, so you can look at that and you can do planning. So if you are capable of doing brachytherapy, MRI at the time of brachytherapy, even without an applicator, it's called a pre-brachytherapy MRI, and you can again use it as a planning tool. So you can just see how much the parameter is and accordingly plan. Most importantly, not separate from what I said, use it for Venetian differences eventual variant applications. Most of the times, the anterior needles we don't usually prefer to load them because they are heavy, because these are heavy, so it becomes significantly contribute to the improvement in the target. The second question is regarding the depth of insertion, right? So the depth of insertion, usually the height of the parameter is approximately 3.4 centimeters. So 4 to 4.5 centimeters is what we are. So we insert the needle around 1 centimeter each to a length of 4 centimeters, 4.5. Again, if you can do a peripheral examination, then you'll be able to find out what is the height of the parameter. If you are used to doing transrectal ultrasound, patient for the length, and practically, if you have we can look at the plan CT of the first application, and then if the coverage is inadequate for the same patient, for the next application, you can use and you can use the information from the plan CT of the first application to guide the test.
We have a second question.
For your presentation. My questions are as follows. So how do you manage settings relating EBRT with regards to your brachytherapy? Because in our setting, most of our patients receive external different center, and now present to another center for brachytherapy. And sometimes we have lost some and how can we manage this kind of situation? Then secondly, what side effects do I anticipate in patients who have brachytherapy operated special brachytherapy administered at the same time? And then thirdly, how do I define CTV, IR, what best
Okay, so I'll take the third question first. Regarding controlling HRCT data, we discussed yesterday in the workshop. There are guidelines, there is recommendations paper. I can share it with you. And like I mentioned yesterday, there is a website called Brachytherapy to use. You just have to discover a course. It's an announced course. It has approximately 30 lectures, mostly from university, and there are very clear videos, long videos as well as short videos on FAQs, short videos with how to do consulting, how to manage side effects, all those things. You can try that. Regarding the first question on I'm sorry, what was the first question? Those accumulation. So when you deliver external assumption the entire HRC, the entire posterior wall of the entire anterior wall of the have received the prescription of the. So when we are adding them to the we always add the prescription. 45 grade. Assumption is that entire region has 45. That we add as part of the whatever doses, it's never a problem. What is your second question? Toxicity, side effects, and costs. So when you're doing intra-therapy plus interstitial brachytherapy in the beginning, you may be a little bit worried about the possibility of bleeding after that. Usually bleeding does not happen in the needle. So bleeding happens when you remove the applicator. There is a small chance that it may happen. Whenever bleeding happens, the first thing happens is whether it is arterial or venous bleeding or venous bleeding. Venous, if it is arterial for a longer time, it is not yet relieved, then you may have but this happens very rarely. The last 6 years of doing brachytherapy at the center, we treat approximately 150 patients every year, and I did not have to do suturing major arterial, not even in a single. So it is quite safe as long as it is done underwriting. So the learning curve is approximately 20 cases. Once you do those cases under guidance, it will be
Put your hands together. Thank you so very much. We appreciate you, Professor Raviteja. I hope I'm pronounced that correctly. Professor Raviteja has done justice to this topic on brachytherapy approaches, new approaches to improve outcome. I think you could see how these approaches to brachytherapy actually improved service delivery. Thank you again. While he was speaking, representative of the chief medical director walked and we now have Professor Mola, who is representing the system. And that's you. I apologize. I take all the Professor Jewola. Thank you, sir. He's a consultant all right, thank you. Doctors are famous for very bad. In fact, we have a journalist at the writing part, and I usually practice when I see doctors in handwriting that they're actually in this place because how they embarrass us and have legitimate handwriting, how dare you complete and absolute. So you are not that for writing, just the pay of this time around. Please let's welcome our rank to give us a few words before we go on. Goodwill messages. Very.
Thank you very much. So let me say welcome to everyone of us. So I just want to spend this few moments comments based on the last topic. So you might be wondering how to get in. We're still struggling with getting applicators and our talking IC and height. So what we have is height, and maybe like 5-6 centers in Nigeria now have IC, and then up till now, until last people only image guided brachytherapy. IC is in Jakarta, and it means that we only have to tell them at both center has tandem and ring. Zambia, we use tandem and to insert that tandem and then of all the centers, only doing image guided actually those to that, whether you are there or not. And then until I think last Kano started. So give it up to them. So other center has ability to do. I already want to start on this. Brachytherapy is just like managing. So nobody wants extra work for added money. And category of patients are such that they cannot even afford. And the best outcome is what if from your external radiotherapy, chemotherapy plus radiotherapy is completed within 7 weeks. That's the best. So we had some instances where patients started, you have done your 5 weeks of external, you want to do brachytherapy, then have to travel all the way and wait another 2 months, 3 months. Of course, it's not the same. So now we're trying to beyond that, our patients are still very young. Even when you have done all of that, after your external, you expect them to have reduced when you for you to be able to use your applicator. Then lo and behold, some patients just standing like as if nothing has been done. So I'm just using this opportunity to tell those in the place of authority, talk to HACOM, talk to NAEC, talk to our Honorable Commissioner of Health, talk to CND, that we need more than what we're doing. Our patients, most of them cannot benefit from the one we have, which is highly inadequate. We need more. And we are seeing the difference. For this summit, we plan free handling to be able to put under the guidance of those knowledgeable and have experience. Only for us to discover that the needles we have donated. We have some that were donated by HIT following the last summit. So they are sharp, so they are not. And we're going to place them manually. I believe all of us now understand when you place it manually. The needles are not experience. It's not even going to work. Whereas technology has gone to this applicator come with those. So all the work has been just reset. And the basis for the needles are there. I will not decide which one to do. It makes life easy. I can tell you that in the whole of Nigeria, in the whole of West Africa, even South Africa, nobody does interstitial. I just said last examination we were there together. We both presented the abstract. That's Professor Ravi. We're both side by side. I was looking at what was presented and what I was presenting. In that way, all of us are So this embrace 3, I started talk. I would like to join this embrace 3, study the one. But when you see the ICS and ICR. Where do we start? So I don't generally know that. We are winners to do it. The best of it is for us to have local data. We have started this. I did a pilot grant on the advanced patient therapy for our patient because of the bucket. For us to downstage and see whether we get. We need to do more. Because of just a pilot study, no grant. We have done studies on vaginal microbiome. See why our patient are responding like that. No grants to do. This is ICM 3 that was last year. Because at the top of it, as his boss and another mentor, we cannot qualify. So we need this applicator because that is what our patients need. Or else we just do what we can.
Recording in progress.
Much more than that. Thank you.
Well said, man. Thank you very much for our work. This is my name for her. She's absolutely right. I think we just need to keep upscaling, and we must seize every opportunity to speak about this need to upscale and do what is right. So thank you so much. And it has been an eye-opener sitting here and listening to some of these things that have been done. I mean, when the first speaker was speaking, and she mentioned something she was doing as far back as 2012. It was in that her presentation. I actually did a bit of soul searching that 2012 is 14 years ago, and what was commonplace for her, which was ultrasound, the use of ultrasound in delineating CSMX, is what we're just trying to take up now and encourage. So it becomes a little bit concerning that ultrasound, they've known that ultrasound scan was equivalent to MRIs as far back as 2012, and they've adopted it, and we're just, so we need to do more. And this is one of the reasons why we gather like this, is to learn what is going on in the world, and then influence our own practice and speak to power and see how we can effect it. Please put your hands together for Mama Brachy, a very passionate woman, always seizing every opportunity to speak. I have to confess that I have a small problem. I don't know protocol very well. I'm just a clinical oncologist. So in case I make any mistake going forward, everybody just please beg for me. in advance so that I don't make any mistake. We're going to have a series of goodwill messages. I'm made to understand that ideally the most senior person on ground will speak last, but I've also been told that he needs to leave. So, may I please ask, sir, our honorable commissioner, would you be willing to stay for the goodwill messages, or you will need to speak immediately? Okay, good. I just want it's safer to ask, sir, and more now for me to goof. Actually, sir, thank you very much, sir. And so, without much ado, please, you people should please be putting your hands together. We have a very great and big person in our midst. Welcome with me, Professor Emmanuel Akinola Abayomi, for his big message. He's the Commissioner of Health for Lagos State. Thank you, sir.
Good morning, everybody. First of all, let me say that most people don't address me as Emmanuel Akinola Abayomi. So when you say that, I get scared. You know you really I've done something wrong. But you can just call me Akinola. It's easier and it's shorter. So let me first of all acknowledge some very important people in the room. Engineer Justine Salu, Director and Head of Research, Nuclear Infrastructure Development Agency of Nigeria, Nigeria Atomic Energy Commission in Abuja. Thank you very much, sir, for attending this conference. And your colleague, Deputy Director of the same agency, Mr. Yusuf. Thank you, sir, for coming to Lagos. And my dear colleague, Professor Abubakar Bello, President of the Association of Radiation and Clinical Oncologists of Nigeria, and also the President of Aortic, that great institution that I once used to spend a lot of time at their conferences around the continent. You know, it's great when you just have these titles, you don't actually realize how much work goes into these titles of president of this and president of that. And so we deeply acknowledge your contribution to the advancement of cancer therapy in Nigeria. And to the representative of the CMD of Youth, in absentia, Professor Adeyemo is represented by Prof. Ojewola, sorry. Is the doctor's writing? Aptly represented by you, a urologist, and I'm sure many of the topics here will involve that ubiquitous disease called prostate cancer that seems to be having a great liking for people of African descent. So I was very happy to listen to at least the last speaker, and I caught the end of the virtual presentation. But let me thank the organizers of this conference. You know, it looks like a small conference, but it's big in impact. Dr. Adegboyega, and the reason I said accepted to come here is an interesting reason. I can't be at all the conferences, so I have to choose and select where I go, otherwise I won't be able to do any work. But because of the shortage of specialist facilities that deal with cancer, various components of oncology management, we have a severe shortage. Severe is even an understatement. So I often have to call my colleagues in the centers that do exist, whether it's a government center or a private center, because people call me. When you get a diagnosis of cancer, your whole world falls apart. And the world of your family falls apart with you. It's that we call it the big C, and it sends shockwaves through you the moment you hear the word. So whenever somebody is diagnosed with cancer, it's always an attempt to reach out to get the best treatment, but also we all know that cancer is indeed an emergency, because the longer you leave cancer, the more chances of it upgrading itself in terms of stages. And your prognosis depends. Sorry, your prognosis depends on the earlier the earlier you're able to identify a malignancy. So I often have to call and beg, and please, can you move this patient up the priority list? And I want to thank all my colleagues in this room who often obliged me. But it is an indication of what we need to do as a collective to improve the statistics. I can quote all kinds of things, and I know the data off head now, because I've had to defend the very big project in the Lagos State Cabinet, the Lagos State Comprehensive Cancer Center, which we're about to start building here in Ikeja. You're not in competition with anybody, because there's no competition when there's a significant shortage. But to complement, and we all know that in specialist disease management, you do need your colleagues. You need the more colleagues you have, the better. Expand your tumor boards and refurbish your patient and discuss patients. You often want to talk to somebody else in another facility. So important to have many centers of excellence within a city, within a country, and within a continent, so that you can refer to yourself. Support yourself management of patients moving forward. But we talk about universal health coverage as government, but we also must not forget this, because everything is not about bread and butter. We do get diagnosed with complicated diseases, self-discipline. And you need, as a country, we need to develop the ability to manage not just bread and butter, but we need to be able to manage specialized cases so that start to chip away at medical tourism driven by two forces. The first force is the absence special center that can manage diagnosis. But the second drive is confidence in the systems. So even if there is an oncology case, or there is a neurosurgical specialty environment, you're wondering, can I trust this facility with my brain inside, tinkering around vital organ of computation, or in oncology, getting those right, how complicated the management of cancer is. I know very well. Done several decades managing biological projects. So I know that it is one of the things you have to pay particular attention to detail. One miscalculation, you overcooked your patient. Something like treatment successful, patients died. It's balance. You have to give the appropriate treatment modality and tax the without compromising patient. So I'm sure we're not here to pat you on the back for me to talk about ecology, what is specialists do that. But I'm sure you've asked me to find out what is government, in terms of how we support aspiring oncologists, and how do we create an environment so that all these specialists in this room are not tempted to jump out of the country, where find much improved amenity. We're talking about leaving Australia, where your segments are really minor problem compared to the kinds of programs here in Nigeria. So exactly what are we doing? And a conference like this, it's not full of thousands of us, because there aren't thousands come together to talk about this. But there are thousands of you all over the world. You all know yourselves. Whenever you travel for a conference, you're busy meeting the same people. And these conferences are so important because it helps you to measure your own standards, and helps you to listen to what other people are doing and bring you up to speed and evidence-based medicine. As you all know, the management pathology in general is becoming more and more precise. In oncology, the ability for assessment depends on a multitude of disciplines, a multitude of specialists. And your pathologists understand your biology. You need to understand radiologists, people who can give you accurate imaging. You need your nuclear scientists, you need your radiation therapy technologists, and then you need your oncology nurses, and then your specialists who are able to make the diagnosis based on collective chemical analysis, and then develop the treatment plan. And the treatment plan is survival. So for us as government, we've been these conferences. Even if we haven't the proceeds of whatever you decide, you take. And so doing, I know, based on personal experience and on facts that we have this shortage. Collective manpower and institutional capabilities as well as infrastructure. So we in Lagos, out of this country, know that we need to do our best to narrow the gap so that we can carry out as much cancer management as we possibly can to dent outbound medical tourism and to give us because not everybody has the capabilities to spend money to fly to Dubai, India, South Africa, Europe, to access the treatment required to maximize your chances of survival. So the first thing we're doing in Lagos, I'm just going to run through a number of initiatives. First thing we're doing is to digitalize the complete health and public health system in phase one, and then phase two is the private sector. What does this mean? So we are about 50% of the process of digitalizing. Digitalization is important, not just because it increases efficiency, but it gives us that currency of resource allocation data. For us, I have data number of cancer cases in Nigeria every year, a number of new cases, so on and so forth. I know what the data is because, but it's not that accurate because it's collected on paper. You have to do a lot of work to gather the data. But if we're able to utilize then it helps us to actually establish the true nature of disease burden, cancer, in this case, in our environment. So that's ongoing. We hope that in the next year or so, at least our public health facilities, which are 30 general hospitals, 300 PHCs, and tertiary centers, that's good. We will have a digital archive of the health behavior, the different pathologies that are presented to these facilities, and then sharpen cancer registry, which at the moment has significant goals. In terms of manpower, we all know there's a serious shortage of generalized medicine, special country. Certainly in Lagos. Generally better than Lagos in Nigeria, because people do train to Lagos in itself is of training Nigeria, and then train Lagos, whichever way you want to look at it. So whenever we put efforts for certain sources to health, we have a flurry of patients from all over Nigeria, and I feel sad about this. Us taking people from other parts of the country. I know that robbing other states, the human resources, health and that equation equates to people not receiving respect eventually die. So it's not for us. We're not happy to say that Nigeria is better than other states. We as a country to work collective so that we're able to narrow this significant human resource that we have in the country. But for us in Lagos, we do what we and we've asked the draft bill for the establishment of a standalone university of health sciences. A university that is purely dedicated to developing human resource for health in all disciplines: doctors, nurses, pharmacists, dentists, medical laboratory scientists, and all the sub all we need is a few people deliver the subject matter, and then we can develop the human resources, nuclear medicine, radiation, oncology. These are all curricular and need to be established. And we're living in a cyber world. So it's possible for us to have these resources not necessarily ground. So that the bill has passed through cabinet, has gone through House of Assembly, Senate, has gone through fast track legislative process. I'm happy to announce that it has been signed to what we call the pre-assent form. All it now requires government to sign and then starts working. And what we're doing is we're transmutating Lagos State policy into a standard so that it can just focus on developing specialists and subspecialists and all the other key areas required for us to provide adequate health care to our citizens. Now, one of the other things is remuneration of services. As you all know, most Nigerians pay out of pocket for their care. In fact, the data is 77% of all spent on health. And that health bill in Nigeria is calculated at 30 trillion naira. So it's not a small economic compartment of the national economy. 33 trillion naira. If Nigerians are spending 33 trillion naira on their health, it's really something that we have to look at. And we're doing that today because we want to reverse the spend source. So if 77% of people are spending money on health from their pocket and about 2 or 3% are using insurance, it should be the other way around. There is a very interesting law that has come out in Nigeria. President Buhari signed law in in 2022, which is the NHI Authority Act, the National Health Insurance Authority Act, which now stipulates that all employers by law need to be carrying at least a minimum insurance package for health. And so for us in Lagos, we've taken that law very quickly, and I think we're the only state so far that has domesticated that law through an executive order of July 2024 by His Excellency Babajide Sanwo-Olu. So now we have the executive order domesticating the NHIA Act, which now means that if you are in Lagos, you see laws are important, but if you don't domesticate them and apply some enforcement, then the law is just getting sitting on the shelf. So what we've done is to domesticate it, apply teeth, which are your enforcement agencies. So what are we trying to achieve in Lagos? We're trying to achieve an environment where most are carrying some form of insurance. Preferably insurance that can cover certain basic lots of companies, but also some aspects that can help you when you get diagnosed with a situation like cancer. And so cancer diagnosis, cancer management is on our list of things put into insurance premiums, so that we all know how expensive cancer management is. It's no longer a simple disease to manage in terms of diseases. Same. It's just that the modalities of managing cancer have advanced. And as you know, there's all advanced, it becomes more and more expensive, have more options at your disposal. And so we're trying to diversify the insurance. We're trying to make sure that many people have insurance in Lagos. We are enforcing the domestication. So it's not going to be a matter of me telling you to have insurance. It's a matter of knowing that if you don't have insurance of one form or the other, there's certain things that you will be able to do to us. It's just like the last strikeout. If you want to send your kids to school, or you want to open a bank account, or you want to do a job with government, one of the requirements that you show is adequate insurance for your financial status. And so how does that influence your experience? Well, it does. Influence is very big. It means that patients are more equipped in terms of funding and principles of insurance to be able to afford the cost, at least the basic cost of medicine, maybe plus or minus some additional costs. But at the moment, most people have to sell their belongings, sell their car, collect kids from school, only because one person has been diagnosed with cancer, and now entire family is plunged poverty. So one of the big things, obviously, is around this new institution that I just described. Lagos State Cancer Diagnostic Center. So we've been pulling this issue because there's the federal institution, which used to be called NSI, now MedCell Youth Cancer. Congratulations to them, because they're doing amazing work to manage it. Thank you. Doing amazing work in terms of managing cancer. We have Lagos, the big place, and certainly we have a lot. So that seems to be almost like the anchor of cancer management. I'm very happy with what's happening with and the collaboration with federal NSI. Federal Ministry of Health. There are a few other private centers in Lagos, like Marcel, I forget the name of one Lekki, and of course there's a small unit in Lasso this institution will now rise to be a partner with medicine because it increase the amount of specialists we have, and hopefully over time we'll be able to develop local capacity. Sure that when this institution comes on board, a few of the specialists will come from different parts of the world to help us establish and build global capacity. But according to our calculations, we know that for the operation of this, we need at least 10 or 15 medicines in Lagos. And we only have 2 or 3. So we have a long way to go to level out that mass of deficiency. Around the whole area of research, we often criticize ourselves as government. Most of the grants available to our researchers in Nigeria are international grants. Everybody here is in grant, and now we're looking out for NHIA, EU, JICA grants. We spend 6-9 months writing a huge grant. 9 times out of 10, I'm very sad to note, saying unfortunately, we were not successful. And you have to go back to the drawing. So for us, we recognize that we need to encourage junior and our middle level research and provide funding, at least for you to have something under your belt. You've written a small grant of say 20 or 15 million naira. And you use that to generate papers and advance yourself as an academic. So that when the other grants come out, the big ones, $1, $2, $3, $4 million, that you've had experience. You have something to write on your application. Otherwise, one of the reasons why you fail and secure these high-level grants that are internationally available. And then ultimately, we as government need to be able to make available to our researchers high level value grants, so that we're not totally dependent on external sources for developing expertise in our institutions of higher level. So I don't want to take much of your time. I think that the little things here that government is not asleep. We're fully aware of shortages. We're fully aware of encumbrances. We're fully aware of the institutional capabilities. And we're doing in a very focused and strategic way. Building blocks that will help us not only to achieve universal health coverage, but also to retire our medical policy and make sure that neither the public or the private sector that these treatments are available to citizens of Nigeria and of Lagos. And we're not just the Ministry of Health and Human Facilities, we're the Ministry of Lagos. And Lagos is comprised maybe 400 health facilities and about 4,000 recognized and registered private facilities. So it's almost a 10-to-1 ratio. So who is providing the care? It's not predominant, but it's a sizable amount of care delivered to Lagos State residents coming from private sectors. So it's important that create an enabling environment for private sector to flourish. Not everybody wants to go to a public health facility in the treatment of cancer. And if you have insurance, and if you have the wherewithal, then you should be able to encourage private sector to help bridge that gap in terms of infrastructure, human resources, and the requisite amount of equipment that you need to deliver appropriate treatment or special. So let me congratulate the summit organizers. Let me congratulate all of you for helping to dial information discussing the importance of us as government. If you don't mind, I can't stay here for all the lectures, but I'll be happy to receive the proceeds of this conference and make sure that I include your sentiments and include your data in our deliberations in cabinet, which where makes decisions based on what is happening in society, helping to create a narrative, improve the environment. What we don't want is for you to throw your hands up and say, I've had enough of struggling in Lagos. I'm going to apply for a job. Saudi Arabia, wherever. We want you to struggle here. I also have done times, and I'm back. Jack by that. One thing when you have Jack, all Nigerians, wherever you are, Cape Town, and East, we know ourselves, and we meet. To eat whatever it is, the flavor of and whether it's Monday, whether it's whatever. We all meet, and always one thing, top of the kitchen, Charlie, enjoying this swallow is always I just wish. So our job is to create an environment for you to come home so that Professor for what and see the last we are working here but I'm happy for what is going on. Really developing my specialist services. So many things happen. We're encouraged by us. Happy for you to compete on Lagos. Because the more excellence there are, better is there. Ife is there. Abuja is there. Kaduna. The more we have, the better. Because we really must provide adequate specialist services. Have confidence. And it's not just about what Professor writes, that's actually his part. It's how is that different? Who's looking after the patient after you have chemotherapy, and the bone marrow is shut down, things like that. That's where the problem is. And the other people after the patient as well, these kinds of situations. So let me apologize. In fact, I have another meeting right now. I'm in the room. Let me recognize DG Nascar. Dr. HIV is a very relevant condition. I spent half of my career as a radiologist finding HIV, which I'm sure were a new phenomenon for us on the continent. And it was needed to understand the challenge HIV is, we needed to understand how to treat HIV in patients who are already compromised. They're not as resilient as the other person, and they're also taking other drugs. So it's a very complicated situation. So this is where specialists. So that's in parallel. So I'm not going to stay for a few more sittings. There was one topic on my agenda that I was keen on listening to. I'll collect proceeds from you after. So on that, let me congratulate you. Let me welcome you. And if visitors to Lagos, the Center of Excellence and the Center of Aquatic Splendor. My friend from India, we have a very coastline. We don't have a mountain like in we have other things. One third of Lagos water. If you like fish or seafood, please organize so that you take our guests Yes, it does. Thank you very much for taking the visit us here. We hope that you're establishing deep and lasting collaborations. We need to learn. There's a lot of infrastructure, science going on in India. We're very impressed with what you do in India. We often use India as a benchmark for all disciplines. Because we're almost sort of similar in terms of our colonial heritage, our age of independence, our challenges, sides. And so they can do it in India. We can do it as well in Nigeria. There's no reason why. I think show. I was listening to this program yesterday. Africa Forward was held in Nairobi. And really, as a concept, we need to recognize that that's our time. And we cannot constantly saying have us, we must find it, and we must establish, we must put it in place, and we must recognize great specialists that choose to remain in Nigeria, take off. And in that recognition, honor you as Nigerian patriots. You've chosen to stay in Nigeria, chosen to stay. Thank you for your attention.
We're going to just really quickly, so that we can have the commissioner feature in the picture. So can we have the organizers and key items? Just come forward. Yes. Dr. Okay. Thank you. Sir, feedback, sir. Professor let's just quickly take a few pictures. Also, our speaker, please join us. Mama Chomi, yes. Thank you very much. Now we're so glad to have you. Please put your hands together for the commissioner as we exit. We thank him so much for coming to share with us. We will take you on the offer for the seafood. I hope you get it. We'll take very brief Google messages because a lot of our time passing up. I have to apologize to everyone, and including our international speakers. Some of them are very late hours when they are now. So we're going to hurry all up before the other speakers. We're supposed to have a break, but we'll make it very short. Grab your tea and sit down so that we can continue with the program rather than take another 40 minutes. So I'd like to for all of our dignitaries just please help us concise most respectfully so that we can move forward as possible. So please welcome with me Professor Bello, who is the president of Association of Radiation and Chemical Oncologists of Nigeria, the past president of the OT. He's also my big brother. He's a financier. I can go on and on. I'm waiting for you to come because I'm moving on. Yes, so Yes, and it was under a system that we were able to get Western Medical College also give the Faculty of Radiation and Chemical Oncology got created as well as the national one. So please put your hands together. Well done, sir. Well done, sir. Thank you. 2 minutes, or 3, or 4.
So thank you very much. I will stand on this protocol because Honorable Minister has taken over time talking about government can't stop. But I know that he will stop if I go more than 2 minutes. So I will be concise. I will not be like Honorable Minister. Not yet. Maybe Honorable in the future. It's really an honor before you. This very honorable gathering for the fourth Brachytherapy Summit, and I sincerely commend others in the important platform dedicated to advancing brachytherapy in our region and beyond. The theme of this year's summit is precision and personalized brachytherapy, advancing innovation, access and outcome, not have been more timely relevant or visionary. Equally important, the sub-theme focusing on WHO survival cancer initiative, which reminds us that our work extends beyond technology and treatment delivery. It is fundamentally about saving lives, preserving dignity, and achieving equity cancer care. Today, I would like to speak the evolving role brachytherapy modern particularly with low and medium income countries, and how this aligns strategically with global survival elimination goal. We know that brachytherapy remains one of the most elegant and scientifically precise form of radiation treatment ever developed. Unlike external beam therapy allows us to deliver exceptionally high dose directly within or adjacent tissue while minimizing the exposure to surrounding organs at risk. Many cancers, like prostate, breast, endometrial skin, head and neck malignancy, brachytherapy remains cancer. Indeed, cervical cancer brachytherapy is not an option. It is curative. Multiple studies have repeatedly shown that brachytherapy is locally advanced cervical cancer can result in local control, reduce survival, and poor quality of life outcome. And yet, despite proven efficacy, therapy remains one of the underutilized and treatment modalities globally, especially in Africa. This paradox concerns all of us. At a time when cervical cancer remains one of the leading causes of cancer-related deaths among women in sub-Saharan Africa, the availability and utilization of brachytherapy should consider public health priority. The WHO launched a bold historic global strategy aimed at eliminating cervical cancer as a public health problem. The target ambitious yet achievable: 90% vaccination coverage, 70% coverage, and 90% access to treatment and care. The famous 1970. However, let me be clear. Without functional radiotherapy and brachytherapy infrastructure, cervical cancer elimination cannot succeed. Surgery alone cannot eliminate cervical cancer. Chemotherapy alone cannot do it. External beam radiotherapy alone cannot eliminate cervical cancer. Curative treatment for locally advanced cervical cancer require high quality brachytherapy. Therefore, brachytherapy sits very high WHO elimination agenda. Personalized therapy recognizes that not two most are identical, not two anatomies are identical, not two patients are identical. Treatment personalization now involves tumor volume assessment, radiobiological optimization, patient anatomy, prior treatment response, genetic molecular profiling, and individualized risk. We are increasingly tailoring applicator choices, interstitial versus cavity approaches, fractionation schedules, and those constraints. Hybrid intracavity and interstitial brachytherapy has expanded our ability to manage multiple tumors, discover parametric disease extension, and recurrent cancers. This has improved outcome patient historically had poor local control. Personalized care also means patient care. So we must be pain management, anesthesia support, psychosocial support, survival care, sexual health rehabilitation, and long-term follow-up. Precision without compassion is in oncology. There are so many innovations, image-guided adaptive therapy, which has now become standard cervical cancer management. We have artificial intelligence automation, 3D printing and customized applicators, surface electronic brachytherapy, real-time telemetry and navigation system, as well as integration of molecular oncology. While those advances are exciting, we must confront painful truths. Many African countries lack functional brachytherapy units, trained brachytherapy specialists, medical physicists, radiation therapists, maintenance support, image infrastructure, and sustained financing system. Some nations actually have no brachytherapy at all. In fact, when I was president, found out that 8 out of 54 African countries have no single brachytherapy machine. And this creates a level of global inequality. The woman diagnosed with cervical cancer, highly income country, they have access to MRI-guided adaptive imaging, multidisciplinary tumor board, and advanced supportive care. Another woman in Africa, there is no functional brachytherapy within her country. This disparity is unacceptable. To close this gap, we must pursue a comprehensive strategy. We must have infrastructure expansion, workforce development, regional partnership, research and local data generation, and policy and advocacy. Precision brachytherapy demands quality assurance. Successful brachytherapy requires teamwork. No single professional can deliver optimal care alone. So the future belongs to interdisciplinary oncology system. This collaborative ecosystem is essential for personalized oncology care. And I remain optimistic. The future of brachytherapy is bright. The science is strong. The evidence is compelling, and the need is urgent. We are moving toward biologically adaptive therapy, AI-assisted planning, personalized oncology, minimally invasive procedure, and data treatment optimization. But technology will not solve our challenges. Leadership will, vision will, partnership will, advocacy will, and above all, political commitment will. So I conclude, permit me to leave you with several calls to action. Let us invest boldly in infrastructure, strengthen workforce capacity, expand access across the region, support local innovation, promote collaboration, and align our national control program with the WHO strategy. Most important, let us remember that behind every plan is a human being, a mother, a daughter, a sister, a wife, a friend. Our responsibility is not merely to treat disease. Our responsibility is to restore hope. Thank you. Together we can transform cancer across Nigeria and beyond. Thank you. God bless you.
No, sir. Thank you very much. Thank you very much. Together, loudly for Professor Bello. We thank you for honoring us with your presence. And thank you for the call to action. Daring us to just keep it improving more and more. And we'll quickly move to the representative of NAEC. I believe it's the director of engineer justice. I'm right. Forgive me for any comment took my paper. Welcome you for just a few minutes. Remember that is in action. You come in and once we're done, and just take your come and put your hands together.
Thank you very much. Some time. I'm just time the protocols. I want to share this business. Inviting Nick. We're here last year. We're here. Stand here on behalf of my two chairmen who are supposed to come together. Just a few hours and it was changed. And it has to be out of the country for to you. I was at the Med-South yesterday. I was received by the same day. The top professors departments were impressed. Basically, what we are in the Nigeria is really just to facilitate what goes on in Nigeria in terms of support that we can receive from the International Atomic Energy Commission. We facilitate the training of Nigerians, especially those that have to do with nuclear related applications in different fields. I'm not a medical doctor, I'm an engineer, but as a national organization for the country, we can facilitate how we can get certain equipment with the support of IEA. We can also help facilitating trainings of your staff. We have done a lot of that in different national hospitals across the country. Though we know most of those that were trained, they have also left the country. Only if you are here. But of course, we keep doing that because we believe one day they will still come back, as one of the commissioner has said. Went back again. We also facilitate expert mission. Maybe you have certain equipment and you require others to come and train your staff locally. You can organize that. IEA can bring sponsor experts to come for a week or two train your staff. We also organize scientific visits, 1 to 3 weeks. If you want to go to another country, look at the equipment, the facility, what they do. We can facilitate few of your staff because scientific visits 3 weeks, and then to be sponsored by. We can also facilitate fellowship, which is 1 to 3 months. Can send staff specifically to nations that you think they have experts that enhance what you do. So these are the things that the Commission can facilitate, not just the national sports across Nigeria, but we are trying to see how we can also help in, as I said, training of PhD levels and also with other vendor countries that have interest in Nigeria. We can also facilitate direct access to them and can enhance the training of staff, some equipment.
A lot of
A lot of equipment
want to is what they call for
sharing.
They can
support up to 60%.
Nigerians can bring
Bring
40%.
40%.
And because
Because
government,
those
international
agencies,
they can
they can facilitate, bring faster
and more easier.
You can also
help
in getting
even at
even at the point that the Nigerian wave
to have a wave
because of the importance of the equipment for
treatment
of diseases.
We are
also working on trying to
have
what we call the purpose research reactor
at
shelter in Buja
that can help
produce some critical isotopes,
especially
short-lived isotopes that we have been bringing from France or South Africa. We pushing the government to see if they can fund it so that ensure
a lot of
queue
the cancer treatment
can reduce.
So these are
some of the things we do
at
the General Education Commission.
and I want
to encourage our institutions, especially under the federal government, to really
get across
to us, as I said, we can
facilitate and it can be
enhanced staff certain equipment that can
be used for making sure
institution
have the
the best
in
this issue.
Once again,
I want to appreciate organizers, the MC, and the president of the CFT,
and all the
participants.
Thank you
very much.
Thank you for sharing much. Yes, the first person to acknowledge it. In fact, it's not for the empty. That's a commissioner. Just for just calling it. I'm very grateful. Thank you, representative of DJ of I know you do a lot. We're very grateful to you for always partnering with us. Again, very mindful of time. We just move ahead, and I would like to call Sima, representing the scale of Blue. So please come and just give us please put your hands together for our chief.
Distinguished guests, ladies and gentlemen, permit me to stand on because of time factor. On behalf of the Medical Director of Lagos University, Professor Wasuna FDS, who will have loved to be here, therefore exigencies of the assembly and representatives. I want to welcome all participants locally and nationally to this important Brachytherapy Summit. I understand that it's the fourth edition and I was told that the first edition was quite successful. And from what I'm seeing today, this is also very successful. The theme of the conference is talking about precision and personalized therapy. And this is not only apt, it is timely and relevant because it speaks to the future of cancer care, where the treatment is patient-centered, data-driven, and of course outcome focused. This is what it is all about. And as we know, Brachytherapy still occupies the management of cancers generally, particularly cervical cancer, which you have a subject today, and of course in prostate cancer and some other cancers. So it is important when we have guidance like this, where we are talking about shift to personalized treatment. It is not only a technological advancement. It is actually a commitment to the right treatment, to the right patient, and at the right time. And with
And with
this,
this,
the
the
outcome is
outcome is
definitely
definitely
different.
different.
So
So
we're
we're
impressed about
impressed
the
about the
theme,
theme,
and we are
and we are
particularly
particularly
happy
happy
because
because youth
with
with
NETSA
NETSAF
hosts the
hosts
best
the
cancer
best
center
cancer
in the
center in the
country, and
country.
we have
We
a
have
number
a
of
number of
patients
patients
being
being
treated there.
treated there.
To the best of
To the
our
best of our
knowledge,
knowledge,
since
since
we
we
started
started
operating
operating
since
since
2019,
2019,
the center
the
has
center
treated
has
over
treated over
15,000 cancer
15,000 cancer
patients,
patients,
and
and that
is
is
quite
quite
significant.
significant.
The soft
The
thing
soft
talks
thing
about
talks about
cervical
cervical
cancer
cancer
elimination.
elimination.
This also
This also
aligns with
aligns with
WHO
WHO
cervical
cervical
cancer
cancer
elimination
elimination
initiatives,
initiatives,
and it
and
is
it is
important for us to
important
know
for
that
us
we
to know that we
all
all
have a role
have
to
a role
play.
to play.
And I think
And
that
I
is the
think that
reason
is the
for this
reason for
summit.
this summit.
I believe
I believe
strongly that if
strongly
we
that
can
if we can
strengthen
strengthen
advocacy,
advocacy,
and
and
strengthen
strengthen
prevention,
prevention,
and of course
and of course
expand
expand
access to
access to
screening
screening
and
and
delivery
delivery
of
of
highly
highly
specific and
specific and
focused care,
focused care, the
brachytherapy that we're
brachytherapy
talking
that we are
about,
talking about,
the
the
outcome of
outcome
cervical
of cervical
cancer
cancer
definitely will be
definitely will
better.
be better.
And
And
eradication is
eradication
not
is not
only a
only
dream,
a
it's
dream,
something
it's
that is
something that is
possible
possible
if we all
if we
put
all
hands
put
on deck
hands on deck
to
to
address the
address the
problem.
problem.
As a
As
teaching
a teaching
hospital,
hospital,
we
we
are
are
uniquely
uniquely
positioned
positioned
to
to
drive
drive
innovation,
innovation,
cancer care,
cancer care,
to build
to build
capacity.
capacity.
And that is
And
what
that is what
Loot
Loot
NLCC
NLCC
is all
is all
about.
about.
I want to
I want
encourage
to
all
encourage all
participants,
participants,
please take
please take
advantage of this
advantage of
meeting
this meeting
to
to
foster
foster
on
on
innovation,
innovation,
capacity
capacity
building,
building,
and of course
and of course
expanding cancer
expanding
care,
cancer care,
not only in
not
Lagos,
only
but
in
in other
Lagos,
parts
but
of
in
the
other
country.
parts of the country.
And
And of
of course,
course,
develop
develop
strategies
strategies
that are
that are
locally
locally
relevant
relevant
and be useful
and
for us
useful
in the
for us in the
country.
country.
At this
At this
juncture, I want to
juncture, I want to
commend
commend
the
the
brilliant
brilliant
efforts
efforts
of the
of the
leadership
leadership
at the
at the
NLCC.
NLCC.
And
And
on behalf of the
on behalf of the
CND, I want
CND,
to
I
say
want to
big
say
thank you
big
for the
thank you
good
for the
work
good
that you are
work that you
doing.
are doing.
The
The
Loot MedSouth Cancer
MedSouth Cancer
Center
Center
is a
is
pride
a
to us
pride
as a
to us as a
hospital.
hospital.
Aside from
Aside
being
from being
beneficial
beneficial
to
to
thousands
thousands
of
of
patients
patients
that
that
I've
I've
mentioned,
mentioned,
it has
it
also
has
pleased
also
our
placed our
institution, Lagos
institution,
Local
Lagos
Teaching
Local Teaching
Hospital,
Hospital,
not only
not
on the
only on the
national
national
map, but
map,
also
but
on
also
the
on
global
the
map.
global map.
So we are
So we are
grateful
grateful
to the
to the
management for the good
management
work
for
they
the
are
good
doing.
work they are doing.
We are
We
grateful
are
to
grateful
our
to our
consultants,
consultants,
many of
many of
whom
whom
are our
are our
consultants in
consultants
lead,
in youth,
and of course
of
others
course
who are
others
not,
who are not,
and
and
other
other
staff
staff
in that
in that
unit for the
unit
good
for the
work
good
that they are
work that
doing.
they are doing.
I as a
I as
person
a
am
person am
particularly happy
particularly
to be
happy
part
to
of
be
this
part of
meeting
this
for
meeting
two
for two
reasons.
reasons.
First of
First
all,
of all,
is to
is to
challenge the
challenge the
management of
management
the
of the
MLCC
MLCC
to go
to
beyond
go
the
beyond
use
the
of
use of
brachytherapy
brachytherapy
for
for
cervical
cervical
cancer
cancer
alone.
alone.
It
It
also
also
have
have
relevance in the
relevance in the
management of
management
prostate
of prostate
cancer. I'm a
cancer. I'm a
urologist, so I'm
urologist, so I'm
passionate about
passionate
that.
about that.
I've had
I've had
discussions
discussions
with some
with
of my
some of my
oncology colleagues
oncology
about
colleagues
it,
about it,
sometimes in the
sometimes in the
past,
past.
but this is
This
almost
is
four,
almost
five
four,
years
5 years
after.
after.
Nothing is
Nothing
happening in
is
that
happening.
regard. I think it's
I
an
think it's
area
an
that
area
needs
that
to
needs
expand
to expand
into,
into,
either low
either low
dose
dose
or high
or
dose,
high dose,
whichever one.
whichever
I
one.
can tell
I
you
can tell
that my
you that my
unit,
unit,
urology,
urology,
is happy to
is happy to
collaborate with you
collaborate with
to
you
make it
to make
to
it
work
to work
just like
just
we
like we
are
are
doing
doing
with
with
cervical
cervical
cancer.
cancer.
Secondly,
Secondly,
I
I
listened to the
listened to
last
the last
speaker,
speaker,
and
and
it was an
it
eye
was an eye
opener,
opener,
and I
and I
sincerely hope
sincerely hope
that we'll be
that
able
we'll
to
be able
apply
to
all
apply all
that he has
that he
told
has
us
told us
in
in
delivering
delivering
radiotherapy, be it
be it
brachytherapy,
brachytherapy or
teletherapy to our
teletherapy to our
patients.
patients.
Because the
Because the
whole
whole
aim
aim
is to
is to
maximize the
maximize the
benefit of
benefit of
radiotherapy
radiotherapy
and to
and to
minimize the side
minimize the
effects.
side effects.
Many
Many
times,
times,
oncologists
oncologists give
give the
the
radiotherapy,
radiotherapy,
be it
be it
brachytherapy or
brachytherapy or
teletherapy.
teletherapy.
We,
We,
as surgeons,
as
manage
surgeons,
the side
manage
effects.
side effects.
So So we can do precision delivery, other use MRI intensity modulated in such a way that those organs of target receive the highest dose to be better for us. We also have lost. I've had to do cystoscopy on patient with radiation cystitis. manage severe urinary tract symptoms, patients who have relations inside, and of course, I've had to do endoscopic treatment to treat restrictions that result from this. So I believe this is the reason for this guidance, to minimize collateral damage to adjacent structures that will make toxicity high and side effects very high. On this note, I want to congratulate the organizers again for keeping the flag running for consecutive years. I believe next year will be better and better. Once again, I welcome you all to Lagos on behalf of my boss this year. Thank you.
Even if you're perfect, I love that call and the challenge to extend gradation brachytherapy services well beyond the issue of service. You are 100% correct. That's exciting because when you position calls to action, then you call us to action, let's go. And thank you for saying that you are ready to collaborate with radiation oncology so that this can establish. And we have to give it to Luz for pioneering a lot of things. I mean, Luz has become the first record in healthcare, and the fact that you have developed this cancer center that benefits so many people. I mean, when patients come back from Luke where I talk about how the center operates like talk about the quality. If you didn't create an environment as an administration, this would not be the place. So we thank you very much and indeed appreciate you. Please once again, ladies and gentlemen, put your hands together for the CMD of the represented by the man. So thank you. Moving on now, there's going to be a small adjustment program. We're going to take on the presentation by Dr. Roger Mosebel. Dr. Roger will be speaking to us on genomic tests, molecular markers, and the emerging role of combining immunotherapy with brachytherapy. Just to introduce her, this Irish name, I hope I'm not wrong, which is a bit of a mouthful for me. I'm sorry if I'm mispronouncing it. Dr. Roger is a medical oncologist specializing in the management of gynecological cancers with a primary focus on systemic treatment of these conditions. She works closely with the multidisciplinary team of surgeon, oncologists, and radiation therapists to ensure each patient receives the most appropriate individualized care. Her clinical expertise spans cervical, fallopian tube, ovarian, uterine, endometrial, vaginal, and bladder cancer. So in a nutshell, and our research is focused on treatment outcomes for women with recurrent ovarian cancer and uterine sarcomas. We thank you very much for joining us. And if you can hear me, please have the floor for your
yes.
Great.
Thanks so much. Can you hear me okay?
Yes, I can hear you perfectly fine.
Great. And can you see my slides and hopefully the correct view of the
Yes.
Or can you see the presenter view? I think you can see the wrong view. Let me share the right view. Share. Okay.
Okay, yes, much better now.
Okay.
Thank you.
Sorry. I just have to be 1 second on my end because I have to get my other slides back up again on my end.
Not a problem. We're glad to go for you. Thank you for being patient with us.
Yeah. Here we go. Okay, well, I'm delighted to be asked, and what a great symposium that you guys are having. And my name is definitely very Irish. I'm all the way from Ireland, but living in New York and working at Sloan Kettering. And I'm going to present on genomic tests, molecular markers, and the emerging role of combining immunotherapy with brachytherapy. And that has now become a standard of care for a lot of the treatment for our patients with cervical cancer. So as you guys all know, despite optimal radiation outcomes unfortunately have plateaued, and chemoradiation and brachytherapy remain the cornerstones of curative treatment. And we really need biologically driven strategies. Cervical cancer remains the leading cause of cancer mortality globally, and in particularly in 37 countries, it is the leading cause of cancer-related death for women. Curative treatment relies on a combination of chemoradiation with brachytherapy, and it is so important that we advance the fields. So in my talk, I'm going to take you through the genomic landscape of cervical cancer, discuss which biomarkers matter clinically, and then build a case for why and how we should be combining immunotherapy with radiation, with a particular focus on brachytherapy's unique biological role. HPV-driven tumors are immunogenic due to viral antigens. So the vast majority of cervical cancers are HPV or human papillomavirus related. And we can, and the biggest thing that I always say anytime that I'm giving a talk on cervical cancer is this is a preventable cancer and we have HPV vaccination. So our push really should be global vaccination, not only for our girls, but also for boys as well, given the HPV-related cancers that they can also develop. So globally, there should be a big effort to eradicate this disease, but in the interim, these are the strategies that we use when the disease does develop. HPV infection causes alteration of E6, E7 oncoproteins, and that causes a whole cascade of events that result in genomic instability. But there is the potential to use immunotherapy to be able to treat this type of cancer. The most common mutation that we see is a PIK3CA mutation that's seen in about 25 to 40% of cases. And we often see PTEN loss. KRAS is much less common. Sometimes we see the HER2 or the ERBB2 alterations, and we often see TERT promoter. Angiogenesis, so blood vessel formation pathway is active, and the extent of immune filtration varies depending on the type of the histologic subtype. Molecular subtypes may be able to predict response to therapy. These subtypes are not yet actionable, but they are highly relevant when we think about how radiation and immunotherapy may sensitize the tumor. The TCGA classification of keratin high versus immune rich versus versus hypoxic have a clinical relevance. Those that are considered immune rich may be more responsive to immunotherapy, and those that are hypoxic may indeed be more radio resistant. So in terms of actionable alterations, cervical cancer, as I mentioned, is immunogenic but very heterogeneous. Biomarker integration is not standard, it's still evolving, and it really has limited routine clinical use. We don't, in the US, have any good PIK3CA inhibitors in this space. They're all investigational, but there are ongoing studies. HER2 amplification, as I will talk on the next slide, is actually targetable, and we do have an FDA-approved drug in this space. But this type of mutation is quite rare. And then TMB high also is quite rare. But there is, again, another indication for immunotherapy for tumors that are tumor mutational burden high. So in terms of HER2 therapy, there was a pan-destiny, a non-breast study that was conducted in multiple different types of solid tumors. And we saw really impressive response rates, not what we would typically see with chemotherapy. So typically in the recurrent setting with chemotherapy, we'd be expecting response rates of less than 10%. But you can see that those with immunohistochemistry, HER2 3+, so the highest type of expression, had objective response rates in the 8 patients that were treated in this study. So it was only a small cohort of about 70 patients, of about 40 patients, I apologize. But in those with IHC3 plus, the objective response rate was 75%. And you can also see that a lot of these responses were quite durable, so a lot longer than we would expect with traditional chemotherapy. So just gives us an inkling that there are some targeted therapies on the horizon. Another antibody drug conjugate that targets tissue factor is also approved in the US. That's called tisotumab. And that tissue factor is ubiquitously expressed on most cervical cancers. So that is now approved in patients who've received prior treatment. And it's a similar type of antibody drug conjugate approach. In terms of PD-L1, we check the combined positive score, or the CPS, and that has been shown in cervical cancer to be predictive for response. It's not a great test, it's definitely imperfect, but it does give a suggestion of who is most likely to derive benefits. So it is something that we look for, and some of the approvals are linked to whether or not the cancer expresses PD-L1. So in Keynote 826, this showed improved overall and progression-free survival with the addition of pembrolizumab, which is a type of immunotherapy. In terms of tumor mutational burden, if I saw a tumor that was a cervical cancer that's TMB high, the first thing I would make sure is that it's not an endometrial cancer. It is much, much more likely that this is a lower uterine segment endometrial cancer, because the lower uterine segment is associated with Lynch syndrome, and Lynch syndrome, often we see MSI high or TMB high tumors. So just something to bear in mind if the clinical picture is a little bit atypical, because it is quite unusual that you would find a cervical cancer that is TMB high. That said, if you do find one, then immunotherapy has been shown to be beneficial in this situation. And as I mentioned, the MSI high or MMR deficient, much more likely that this represents an endometrial cancer. You could do HPV staining to see if it's a HPV associated cancer, and obviously the immunohistochemistry for the mismatch repair proteins. In terms of emerging biomarkers, so because it's so HPV driven, we are trying to better stratify our patients according to whether or not they have evidence of circulating HPV DNA or circulating tumor DNA, which is ctDNA. So these kind of assays, they're liquid blood tests that are being used to try and assess response, and also to look in terms of monitoring, looking for early signs of recurrent disease. Other things that are being looked into are TILs, or tumor infiltrating lymphocytes, interferon gamma signatures, and more recently, and I think relevant to your group, would be hypoxia signatures, because if a tumor has hypoxia signatures, it may suggest that this tumor is going to be a little bit more radiation resistant. So in terms of the rationale for giving radiation to elicit an immune response, the radiation itself causes immunogenic cell death. That results in neoantigen release from the tumor, and then it results in T cell activation. So this whole process activates dendritic cells and enhances T cell priming, which really improves the immune response to the tumor, not only at that site, but also elsewhere in the body. And there's a very important pathway, that's the cGAS-STING pathway. So following radiotherapy, cytoplasmic double-stranded DNA stimulates a cyclic GMP-AMP synthase, and that's the cGAS stimulator of interferon genes pathway, and that results in interferon production. This pathway then drives immune activation after radiation. The radiation itself also causes cytosolic DNA accumulation, activates this pathway, and promotes a type 1 interferon response with stimulation of the immune system. So each modality that we think of when we're talking about radiation plays a distinct role. So in terms of external beam radiation, the idea here is that it would prime, and then you have the boost with the brachytherapy, and then you give immunotherapy to enhance the response. So the advantages of the external beam is that you have broad tumor exposure. It allows for immune priming. And then with brachytherapy, you're able to give a high dose focal boost to the tumor bed, and that can result in antigen amplification, and then the immunotherapy will be able to sustain the immune response. So there's also some anecdotal evidence for an abscopal effect. And so what is here is you radiate one site, but yet you see regression of the cancer at another site. So for example, you may radiate a lung nodule, and then you have regression of non-irradiated lesions in the abdomen. This is rare in isolation, but it is much more likely when we give immunotherapy. And it is definitely a proof of principle for systemic immune activation. And sometimes in my own clinic, when I'm giving a patient immunotherapy and there's one escape lesion, I may reach out to my radiation oncologists to see if we can radiate that one lesion. And often we see then nice, good control again. In terms of the standard approach to treat cervical cancer, we break, especially locally advanced cervical cancer, we break it into two main categories. Those that are appropriate candidates for a radical hysterectomy, and they're broken down into low risk, intermediate risk, or high risk, and that determines whether or not they need postoperative radiation. And those that are not appropriate for surgery, so those with more locally advanced disease, such as stage 2B to 4A, they undergo definitive chemoradiation. Cisplatin is given 40 milligrams per meter squared weekly with a cap at 70 milligrams, usually for 5 to 6 treatments. And then we also combine brachytherapy for that patient population. And now more recently, for those who have node positive disease, using the newer staging system, which is the FIGO 2014, those with stage 3 to 4A disease can also receive pembrolizumab. That is a very small population of our patients. It does require to have nodal disease. So why, and what about in metastatic disease? So we talked just there about locally advanced, but those with advanced disease, Keynote 826 showed that there is a clear role for immunotherapy, the addition of pembrolizumab to chemotherapy for those with metastatic disease. And then there was the Empower Cervical 1 trial, which gave another checkpoint blockade called cemiplimab. And so both of those trials were positive and showed a benefit to the addition of adding immunotherapy in the metastatic setting. So diving a little bit deeper into the locally advanced trials, Keynote 18, as I mentioned, this was for locally advanced disease, and FIGO stage, it used the FIGO staging 2014. They had to have node positive, 1B2 to 2B, or any nodal status if it was very advanced disease. They added pembrolizumab to radiation, and that improved outcomes for patients. And then this is what the schema looked like. Patients were randomized 1:1, either with immunotherapy given during the chemoradiation, followed by an immunotherapy maintenance for 15 cycles afterwards, versus just chemotherapy and radiation and brachytherapy alone. And this was the results of the A18 study that led to the approval in the US. I will have a caveat though, there was negative trials. So this is the CALA study. A slightly different patient population was studied in this, and this was a negative trial. So we're very careful to ensure that if we are giving pembrolizumab, that we really stick to the FDA-approved label and really ensure that it's those patients that were shown in the A18 study to benefit. Another thing that's being used more widely elsewhere in the world is the interlace study, and this is where you give induction chemotherapy before you start your radiation. The really great thing about this study is that it does allow some time to set up radiation. And this was a large phase 3 study. It was conducted over a 10-year period, so it took quite a long time to accrue. It was an international study, and it was for patients with FIGO, and in this case, it was FIGO staging 2008, so an older staging system. Stage 1B with node positive, 1B2, 2, 3B, or 4 disease. And most of the patients had more early stage disease, so 87% had less than or equal to stage 2B. And they compared standard chemoradiation versus giving induction chemotherapy followed by standard therapy. And in this study, there was a benefit to the induction chemotherapy. And as I mentioned, this is definitely an option where there may be some delay in being able to start chemoradiation. So a very good proof of principle, and definitely something that I think is a very realistic strategy as well if you have access to chemotherapy. In terms of when we should give immunotherapy, we don't really know what the best time is. There are different options. You can give it concurrent. You can give it before with induction. You can give it during the radiation, and we feel that probably there is a role for maintenance immunotherapy. And so we're currently conducting a study through the NRG. It's called GY037. And it's basically building on what the two strategies that I just talked about. So it's giving the A18 arm, where you give the cisplatin radiation and immunotherapy, followed by immunotherapy maintenance. And in arm 2, it's an induction chemotherapy. So like the Interlace study, but this time they're adding in pembrolizumab. So all arms have immunotherapy, and patients will be randomized 1-to-1. This is for the patients with the most advanced disease. So it's FIGO 2018 staging, and they are looking at patients with stage 3 or 4 disease. So much more bulky disease. And the idea here is to see which of the strategies will be the winner, with both including immunotherapy. So where was brachytherapy in these trials? Well, it was included in most of the definitive chemoradiation trials, but obviously hasn't been pulled out separately. So its relative contribution is not clear. And obviously there's a key gap in our knowledge of how brachytherapy itself modulates the immune response. We do know, though, how important it is for our patients who have residual disease that they do receive the brachytherapy and that they receive it in a timely manner, and definitely outcomes would support that as well. In terms of the potential advantages for brachytherapy itself, the idea is that it likely amplifies the immune activation. It's able to deliver a high dose per fraction, and with extremely high biologically effective doses delivered to the tumor bed. And so this has a potential for